Well, we're very lucky today to have two very knowledgeable guests. One I work with on a regular basis, and the other person is a person who's been very, very supportive of our needs when it comes to cognitive decline, dementia, Alzheimer's. Just a great resource. That's Sharon Cohen and my genetics compatriot, Jessica Gu. Before we actually get started on content, Jessica, maybe you can give us a little insight of what took you down the path to get to your genetic role with us.
Absolutely. So I first became fascinated with genetics in high school, actually. It was one of the first lessons that I remember running home and calling my grandmother, who lives in China, and trying to explain with minimal Chinese what I had just learned. And I had never done that before. And so in undergrad, I started exploring different opportunities where I could kind of take this love and passion for genetics and make it into a career. I stumbled upon the field of genetic counseling. It was the right fit. I went to grad school and obtained my master's in genetic counseling, and I've been at Medcan since 2015 and absolutely love this field.
Well, I can tell you, I watched her ascent at Medcan. It was rather quick and appropriate. So she's been a great addition. Well done. Now, Sharon, you've got a longer career. In fact, we go back a ways. We're not going to say how far back. That would be a little bit embarrassing since you look better than me. But maybe you can tell us how you gravitated towards first neurology and ultimately to your current world-renowned status in the world of cognitive decline.
Thanks, Lorne. I also, like Jess, was since childhood fascinated by the career I ended up taking. It was the brain. Why do we speak? How do we learn to speak? Why do we think what we think? Why do some people behave this way and others another way? And that stayed with me through childhood into early university years. But sadly, or to my benefit, I liked so many other things, so I went into art history. I had a very artistic family with musicians and literary people. Art history was my first love at university. And then speech pathology, because I thought, oh, those medical textbooks, they're so huge. How will I ever read them? Then I wrote essay after essay in speech pathology and thought, when I finally get to medical school, this is going to be a whole lot easier. And it was. So my interest in language, thinking, memory, the brain stayed throughout my lifespan. And I really view the brain as so magical, mysterious, fascinating, an incredible organ. But what goes wrong in human behavior and with people's lives when the brain doesn't work is also of huge interest to me. At the time that I chose to specialize in behavioral neurology, I didn't know of anybody in my family with Alzheimer's disease. Sadly, my mother, my father, both my grandparents developed this disease. So that was sobering, but it kept me passionate and gave me even more resolve. It's a privilege to assist patients and, of course, to care for your own family. And we are moving forward in this field. So that's the bright side, and we'll talk about that.
You know, it's very interesting to hear backgrounds because, I think that medicine is really a composite of many things. And life experience is one, passion, but also diversity. And both of you have a real commitment to your passion, clearly, because you both found that as a driver into your careers. But then the eclectic nature of your backgrounds, I think, enhances the way you go about thinking yourself. So it is, I think, a credit to you that you found your way through different avenues into something that you became the expert in. So on that note, it's interesting. I see patients every day. And if I go back 20 years, and I can go back 20 years, that's part of the problem, is that they would talk to me about concerns that would involve mainly cardiac, breast cancer, cervical cancer, things like that. I can tell you now that one of the top 3 items that I hear is concern about dementia. It's just taken a new kind of importance in the lives of people, not just for their own concern, but for their family concern, friends of theirs. So I've just watched this ascend in the hierarchy of thought and concern. So When I see a patient, often they come in and they say, I'm worried about my memory. I'm forgetful. I'm not as sharp as I used to be. I think I've got early dementia, early Alzheimer's. And I look at them and say, we have to think about you in different ways. Natural decline versus dementia. Maybe you can help us understand, Sharon, how you are able to settle that issue, give some comfort to people who are really going through that natural aging mental process versus those where you really have to be concerned.
Right. So this is a really important topic because people do worry about their memory. We're past the days where we just put this down to stress or not sleeping well. We know that Alzheimer's disease affects 55 million people in the world, and the numbers are going up. So most of us know somebody either in our family or amongst our friends who has, or a family who's dealing with this disease. It's very common. And Alzheimer's disease starts very gradually. And so it can easily be mistaken for normal aging. I'm a little bit forgetful. I can't come up with words as easily. Isn't that what we all go through? And you speak to your friends and they say, yeah, I have that too. No big deal. And so we reassure each other. But really, for you, that might be the beginning of a disease. For me, that might be normal aging. We're not being very scientific about this. How do we measure this? What we recognize since 2011 is this is about a 30-year disease. And the first 15 years or so, a protein in the brain, or several proteins, are building up, the first one being amyloid. And people may have subtle cognitive changes, but you do their memory testing, it's normal. And we used to sort of reassure people falsely and call them worried well as if they were neurotic, how insulting, because they could detect something, a change in themselves, before we could pick it up on our tests. So we can now detect that what we call preclinical Alzheimer's with a PET scan or a spinal tap. We see amyloid building up, but the person might have normal cognitive scores. So if somebody's coming to me and saying, I'm not the same as I was, something's changed, and I say, okay, well, let's talk about it a bit, get more history, what's the family history, but then I would also do memory testing. If I'm not finding anything on the testing, I would say, that's good. Your testing's normal, but that's not the end of the story. We can go a step further if you want and rule out Alzheimer's if that's what you're worried about. Then after about 15 years of amyloid building up and other proteins changing in the brain, there's a period of what we call mild cognitive impairment due to Alzheimer's disease. That lasts on average 5 years. And here people are still independent in daily function. They're living in the community. They may be banking, shopping, driving, working, traveling, but not with the same efficiency, not with the same confidence. They may find adaptive ways to compensate. So they're still independent. But if you do their cognitive testing, memory or some other cognitive domain is not what it should be for age or education. So there we say, I see what you're talking about on the testing, but you're still independent in function. So this is mild cognitive impairment. Could this be due to underlying Alzheimer's? Best case scenario, PET scan or spinal fluid, get the answer. And then after 5 years or so of mild cognitive impairment, this seamlessly transitions into the dementia stage of Alzheimer's, if we're on that Alzheimer's trajectory. And by dementia, we simply mean that people are no longer able to be independent in daily activities. So it might be initially that I can't work or I can't drive. And it's harder to pick up in seniors if they're retired and not doing as many things as they used to. So they're not really fully testing themselves against their peak performance. But over time, through mild, moderate, severe stages of dementia due to Alzheimer's, there's more definite decline. And sadly, most people are still picked up in the late, mild dementia phase. And so we've lost 20 years of the disease, where we talk about being proactive in medicine, picking up things early, being prevention-minded. Most people have to get quite symptomatic. Sometimes they have to get lost in a blizzard in the winter before somebody realizes, hey, Grandpa wasn't okay, which is really a shame. We've moved so far in other areas of medicine, cancer medicine, detecting early. And with Alzheimer's disease, many are treating this or detecting it at the metastatic stage, if you will. If you make the cancer analogy, that it's just, the brain is beyond salvaging. So the good news is we can diagnose early, and it's important to do that.
How would you suggest that a primary care physician actually handle that in a way that kind of unmasks the earliest stage, that early 15-year stage, or even the following 5 years.
Right.
How do I get better at this?
So a few ways. If there's some red flags, like a family history of Alzheimer's in a first-degree relative, so mom, dad, sibling, that doubles the person's risk of having Alzheimer's. If they're 65 years or older, that also, this is an age-related, not age-caused disease, but the prevalence goes up. One in three at the age of 80 have Alzheimer's. By the time we get to 90, probably, 50% have the disease. It's not fair. Shouldn't be a reward for living well and living long. Hopefully in the future it won't be. But so age, family history, if the complaints are progressive, even if you're not picking up much on testing. And in terms of the screening tests, the cognitive tests, an MMSE doesn't have the sensitivity to pick up mild cognitive impairment. It's about 17% sensitive. Yeah. So you need something like the Montreal Cognitive Assessment. Also a brief screen. So what you pick from your toolkit is going to matter. Otherwise, we're going to have all of these people who are scoring normally. And of course, we want to reassure people. Nobody wants to have a diagnosis of Alzheimer's. Mm-hmm. But false reassurance doesn't help either, because people lose the opportunity to be proactive. Fortunately, there are Alzheimer's prevention trials now. This is something new in the last few years. And we have many people who say, okay, that's great, doc, my cognitive testing is normal, but if I'm at risk for Alzheimer's, I'm interested in a prevention trial, especially if they've had family members who have been affected by this disease. They've seen it up close, they know how bad it is. And so they screen for a study. They get a PET scan through the study. It's pretty easy access that way without cost. And if they have amyloid accumulation, then they have the option to go on an antibody therapy that draws amyloid out of the brain. And hopefully in the future, this will cross the finish line as an approved therapeutic, and we'll have a prevention.
I want to come back to that a little bit later, the whole concept of amyloid and tau and et cetera. But because I have some questions about that may actually reverse the thought process. So I'm going to come back to that. But, at Medcan, we have, I think, a high level of focus on cognitive performance, on optimizing behavior and minimizing mood disorders. So we kind of get into that first through the doctor because the awareness is high. Second, we've got a mind station that looks at Montreal cognitive testing and other more sophisticated models of testing. And we're able to at least kind of pull out a little bit more information. And then we've got Jessica, who is on the genetic side. So maybe you could talk about how patients arrive to you once they're at Medcan. What are the sort of impetus of patients to get to you?
Yeah, absolutely. Maybe I'll start by giving a brief genetics lesson on specifically on late onset Alzheimer's disease. We're talking about the age-related type, and then I can talk a little bit more about patient motivations and interests. So there's been a lot of talk about a gene that's called ApoE. So if we remember back to our high school biology days, genes are instructions to code for a protein that carry out that instruction. ApoE is a gene that codes for a cholesterol transporter. Now we have many cholesterol transporter genes, but the ApoE gene is the only one that actually works in the brain. So it's really critical for maintaining the health of our brain. It's important for the insulating layers like myelin and for some of the membranes where these neural processes are triggered. Now, there are three, let's say, versions of the ApoE gene, and they're called the E2, the E3, and the E4 alleles. The E3 allele is the most common one. We don't really believe it has any significant impact on our chance of developing Alzheimer's disease. Whereas the E4 allele is actually currently the strongest known genetic risk factor to develop late onset Alzheimer's disease. Now, the jury's still out, but it's thought that the E4 allele encourages these amyloid and tau and plaques to accumulate in the brain, and they're cleared less than they should be. And that's maybe where we can see an increased chance of developing Alzheimer's disease. There's actually also that E2 allele that I mentioned that is thought to be protective against Alzheimer's disease. Now, some patients do come to me and say, you know what, I have a family history or I have memory concerns, and I'm interested in exploring genetic testing options for dementia or for Alzheimer's disease. And one thing that not everyone may be aware of is that the ApoE gene is just a small part of the puzzle. So what I mean by that is it's estimated that about 60% of individuals who have Alzheimer's disease, late onset Alzheimer's disease, have at least one copy of the E4 allele. I say one because we have two copies of all of our genes, right? One from mom and one from dad. But that means that 40% of people with Alzheimer's disease don't have that ApoE4 allele. So that did not contribute to them developing the condition. So to me, I say, you know, the ApoE gene is like a corner of this puzzle that's incomplete. And you're trying to predict what the puzzle will look like based on just looking at the corner. Family history, like Sharon said, is another big predictor. But there are so many other pieces of the puzzle that we don't know about yet, or we can't easily predict. So one of the things I talk to clients about is the limitations of making any sort of diagnosis or even life planning around such a small piece of the puzzle. We still have so much to learn. There are people who are really just interested in their risks, regardless of the limitations. And we do talk about what's available in terms of genetic testing. We have what we call whole genome sequencing, and it includes the ApoE4 allele. But by itself, it's not going to definitively say whether someone will be diagnosed with Alzheimer's disease. And often based on our conversations, some clients will say, this is a perfect test for me, or this is absolutely not what I thought it was, and maybe it's not the right fit for me at this time.
Well, you know, it's interesting because you see them, and your description is actually beautiful. I must say, it's puzzled out in a way that I think makes great sense to me. But one of the things we know about patients is they don't absorb the information the way you give it. And after you see them, they'll come to me and say, you know, I'm going to have Alzheimer's disease. I go, how do you know that? Well, I've got the bad gene. And I go, well, whoa. And so it's interesting that even though we're using more and more tools that we put some degree of reliance on, often patients are not able to discern what exactly that means to them. So they make assumptions. It's confirmational bias. Oh, I knew I shouldn't have done genetics because they told me I've got Alzheimer's. I go, well, I'm not so sure about that. So, you know, no matter how much we hammer home, I think education will become more and more important for our clients, our patients, so that they can understand that it isn't hopeless. You get some information. It's only a part, as you say, of the puzzle. And we will be able to encourage them in other ways to reduce risk over time. And there are ways, and we'll get into that a little bit later.
And maybe, Lorne, I could just expand a little bit on the genetics, because I have a bit of a different spin. We do a lot of ApoE genotyping, testing of the ApoE gene in our clinic. And also deterministic gene mutations. So these are the gene mutations that actually directly cause Alzheimer's disease, which are rare. We all have ApoE genes. These are not mutated genes, and about 25% of the population have an ApoE4 allele. But gene mutations will be a rare cause, but a very well-known cause of Alzheimer's disease. So when I have a patient who's interested in genetic testing, and many are, especially if they have a family history, I say we can do two types of genetic testing. We can look for the rare genes. Since your mom and your maternal grandmother had Alzheimer's, that makes you a candidate to look for these rare gene mutations. If you've inherited one, that's a very serious conversation that will follow, because then it's just a matter of time before you develop Alzheimer's. Do you want to know that? And there's transgenerational impact, because if you have a gene mutation that causes Alzheimer's, each of your children have a 50% chance of having that. That's one conversation. You'd be surprised how many people do want to know, because I pair that with, if worst case scenario, you do have a gene mutation, there are prevention trials now for people just like you.
And this is for that hereditary form of Alzheimer's
So for
disease.
the ApoE gene, I'm very careful to say there are risk genes and protective genes for Alzheimer's disease. They don't guarantee that you get or don't get the disease, but they do inform us about risk. And the ApoE gene, the ApoE4 type of ApoE, as you said, is the one that confers the greatest risk. But there are many other genes. We don't routinely test for them, TREM2 and other genes. In the future, we will probably do a sort of a multiple gene analysis to really better define risk, because if you have, if you don't have an ApoE4, but you have, 8 or 9 of the lower risk genes cumulatively, you may have a high genetic risk for late onset AD. Now, ApoE4 doesn't just increase your risk of Alzheimer's, it lowers the age at which you'll develop Alzheimer's disease. And this matters to people. So, I think it's important information, but as you said, Lorne, people need to understand clearly, this doesn't guarantee Alzheimer's. It tells us it's time to really make sure we're looking after you and giving you all the options.
Well, that's very helpful because, I think that when you look at society as a whole, and with the more, let's say, more educated that we become, there's a lot of consumer-driven behavior that sort of elevates the game anywhere. So it may be that back entry point for you may be the biggest area of growth going down the line, and an opportunity to enroll them in really good studies. So that's really encouraging to hear. Congratulations on that side.
Thanks, Lauren. Yeah, patients know. We learned when we studied pediatrics, listen to mom. She knows what's wrong with your kids. Well, why don't we listen to adults who say my memory is failing?
That's a very interesting point, because when I'm doing, let's say, a face-to-face with a patient, and then a family member is accompanying that person, I will always ask, and what's your comment or response to that? Or what are your concerns? That is an eye-opening experience many times, and getting a much better perspective on what really is going on, whether it's in the cognitive side, whether it's in pain. People with underlying cardiac disease, it was just heartburn. Well, why did, the wife or the husband of the wife having it will then say, no, don't you remember? You had to sit down. You were sweating. You were nauseated. I was going to call 911, but you said, give me 5 more minutes. So, I think that having that second person as a witness with disclosure is often very helpful. I don't know if you find the same.
Absolutely. With cognitive disorders, extremely necessary. And even when people seem very high functioning, high level, let's say mild cognitive impairment stage, we still like to hear from an informant, a family member, because that may really tip the scales as to what's going on. And even though, cognitive decline is a scary thing, and there can be psychological denial, just like with an MI, no, not me, I'm not having a heart attack. Not me, I'm not having Alzheimer's disease. There's more than that. The part of the brain that allows us to judge our own behavior, to remember what we don't remember, doesn't work well in Alzheimer's disease. So a large proportion of individuals who are developing the disease, even early on, don't think anything's wrong. They're aware their family's not happy with them. The family's on their case. They think, the problem's the family, not me. And they'll tell me that sometimes. I don't have any problems. It's just my husband who won't stop bugging me. And I have to explain to them and their family, I know that it doesn't seem right that you wouldn't know what's going on with your own brain, but this is what this disease can do. The insight can be impaired very early. Other people have preserved insight with Alzheimer's disease, so it's sort of a broad spectrum. Yeah.
Now, these days we have to be careful how we ask questions or make inferences, but is there a gender inequality in Alzheimer's?
Yes, there is. And I don't feel any compulsion to sugarcoat this. Sadly, women are overrepresented with Alzheimer's disease, and we see this over and over again in every study, population-based study or clinical trial. And women are also overrepresented as caregivers. And why is this? There are probably some biological reasons for it, but that's likely not the whole explanation. We know that building cognitive reserve, if women don't have the chance to have the same degree of education, the same type of occupations that would allow them to build cognitive reserve over their lifespan, the same degree of socialization, this can make them more vulnerable to a disease that gradually wipes out brain cells. And women live longer. So the men get picked off with heart disease. That's changing. But, in an age-related disease, it used to be said, well, women get Alzheimer's because they live longer, and the men, if they lived as long, wouldn't. So there are a number of different factors.
Now, is there anything else on the pathophysiology that we should know about? You gave us a good insight into amyloid, how it gets deposited. It takes time to build. On tau, the role of the genes, potential role of genetics in that cascade effect. But is there anything else that we should know?
Yeah, so the earliest change we can see in the brain is the accumulation of amyloid. And it happens throughout the brain. It doesn't correlate in terms of region of the brain causing specific symptoms. So it's not that amyloid's just developing in the memory areas. It sort of grows to a certain density of plaque, and then it triggers tau, this other protein, which is within the brain cells itself, to misform, to clump together. And then the brain cells themselves start dying. And before the brain cells die, their connections to each other and the way they communicate with each other through synapses are disrupted. So you get a smaller number of synapses, you get a smaller number of brain cells. By the time you get to mild cognitive impairment, you've lost millions of brain cells. It's a huge loss. But there's more. So tau starts spreading in the brain about 5 years before symptoms arrive. Amyloid starts accumulating, as we said, 15 years before. But throughout this whole time, maybe at the beginning and definitely as the disease progresses, there's a reaction from the immune system. So there are inflammatory cells that contribute to the damage in the brain, that contribute to chemical release that injures the brain further. And the immune system may actually be dysfunctional at the beginning of the disease. So many of the therapies in the drug development pipeline for Alzheimer's are targeting the immune system. Some are targeting amyloid, some are targeting tau, others are targeting the immune system. In the end, projecting a few years from now, we will likely have a cocktail, something like a cancer chemotherapy cocktail, where we're tackling different elements of Alzheimer's pathology, not just amyloid, tau, but inflammation and maybe other components. And it may be stage dependent, again, the way we do with cancer therapy. If you're at the preclinical stage, maybe just tackling amyloid will be enough to stabilize this. If you progress to mild cognitive impairment, then we add an anti-tau agent. So you can see different ways that this could evolve. And to me, that's exciting because we've stagnated for a long time and we need new therapies, and they're coming. And one thing that's so exciting about the Alzheimer's drug development pipeline is not just that there are over 100, there are about 146 drugs under development at different stages, phase 1, 2, and 3, so they're spread out, but they are in multiple different areas of mechanism of action, meaning they act on different targets, amyloid, tau, inflammation, and in different ways. So even an anti-amyloid drug could be one that clears amyloid, it could be one that prevents amyloid from forming in the first place. And we know from these rare deterministic gene mutations that directly cause Alzheimer's, they're rare, but there are over 300 of them. They all act by increasing the production of amyloid, every one of them. So this is very strong genetic evidence that amyloid is the early change. And some of the therapies being developed now are to stop the transcription of amyloid from RNA to protein, or to interfere with the RNA in other ways. So it's become a lot more sophisticated, trying to get at the heart of it, but not to the exclusion of other mechanisms going on in the brain. And downstream, the drugs that we've had approved for Alzheimer's for over 20 years, the commonest brand name is Aricept or donepezil. These work very modestly. We were excited when they came along because we needed something. But you're treating way down when the synapses are no longer there or producing acetylcholine, and you're trying to boost the amount. And these drugs boost the amount modestly and bring about very modest benefit. But perhaps there will be cholinergic drugs or drugs working on other neurotransmitters that can more substantially boost those chemicals in combination with disease-slowing drugs. So, there's an interest in coming back to them, but not in the format they are now because they haven't been substantially effective.
Well, Jessica, let's go to the genetic side of things. We hear about CRISPR's gene editing, it's kind of the flavor of the day. Not that it hasn't shown material value like in sickle cell, for example, and thalassemia, etc. What's your understanding of its application to something like Alzheimer's?
Yeah. Well, drawing on some of what Sharon was saying, talking about the two mechanisms of Alzheimer's disease, there's the hereditary form and there's the late onset form, which is a lot more varied in the factors. With the hereditary form and those really rare mutations, I think that is an area where CRISPR could be helpful. Those are true mutations. They're in every cell of your brain. CRISPR is a technology that theoretically could cut out that mutation and give the right gene variation instead. But similarly, there's a lot of talk on gene therapy with ApoE. Can we reduce the expression of the ApoE4 allele? Or can we promote the expression of the ApoE2 protective allele? Again, it's just part of the puzzle, but as we learn more about these other genes that can have an effect on late Alzheimer's disease risk, maybe ApoE4 is the biggest piece of the puzzle, but these other genes might constitute one or two pieces at a time. We could probably target those as well. And it might be something that gets used in conjunction with all the other therapies and drugs that are being investigated. Because I think at the end of the day, treating this disease through multiple different pathways might be the most effective ways. And genes and genetics is just one part of it.
I'm hearing some very encouraging things. It's not that I'm hearing a timeline, because I think in medicine we've learned that it's very difficult to predict what the outcomes are based on the complexity and the permutations and combinations of things that interplay. But you've certainly given us, when I heard the number of studies that are currently involved, I must say that was an enlightenment for me. I did not expect that kind of expansive nature. And I think the encouraging thing with CRISPR or gene editing is that we've added a modality, not a treatment, but a modality that may be interspersed with things that are being done on your side. I think that Medcan has a theme: eat, move, think. Why don't we comment, and maybe you can begin, Sharon, with the things that, from a lifestyle perspective, you believe are important to limit progression or as prevent it in itself from a lifestyle perspective.
Sure, I'm happy to. So when we talk about lifestyle strategies that promote brain wellness, we think in terms of exercise, physical exercise, and cognitive engagement. So from the standpoint of physical exercise, unlike with an athlete training for a specific sport, moderate intensity exercise of any type, whether it's dancing, gardening, jogging, golfing, whatever you like, is helpful for the brain. It used to be thought that physical exercise, as far as the brain was concerned, allowed better blood flow to the brain. But that's probably only a minor component because the brain has vascular autoregulation and so it doesn't really rely on the heart being, an even better pump. What physical exercise does, though, is it promotes the release of neurotrophic factors in the brain, so nerve growth factor and others, which are essential for brain growth and repair and actually sprouting new brain cells. So when we were in medical school, or I'll say me because you're younger than me, right?
So how dare you? You know the real truth. Of course not.
Well, together.
I'm your father.
Oh, no, that's not true. Together we learned that you were born with a certain number of brain cells, and then that was it. It was all downhill after that. Well, that's actually not true. And so you can grow new brain cells, even in the adult brain. And interestingly, the hippocampus, the memory area of the brain, is a particular place where you can do this. So exercise helps. Cognitive engagement also helps. And here we're not so much talking about speed and reaction time, so shooting at targets, that might be fun, but it's more problem solving. And problem solving can be the classical game of chess, or it can be traveling and having to figure out your schedule and routes and time zones and different currency. Anything you like. People will say, learn a new instrument, learn a new language. It all sounds very pressureful, but people should do what they like. We don't learn well when we're doing things that feel punitive. So if I give you homework because I want you to improve your memory and I give you a book of crosswords and you don't like crosswords, that's not the right solution. But if you like crosswords, up the level, make it a little bit challenging. So that's kind of what we teach people in terms of stay mentally active. Everybody needs to relax in front of the TV now and then. Don't beat yourself up about it, but don't make that the predominant lifestyle.
I really appreciated hearing from you the statistic that these lifestyle strategies can have a 30% risk reduction on dementia. It's huge to know that number. And I also appreciate just you saying it doesn't have to be that you have to learn piano when you retire, but you could travel.
But do it if you want to.
Yeah, of course, if you want to. But I took piano and it was very punitive, but but you could go traveling and figure out your schedule, figure out a route, figure out the time zone.
And what we're doing today.
Right.
We're listening to each other. We're trying to figure out where we're going with this.
Right. And problem solving can be so fun and not a task.
Right. We look at our puppy dogs, they like to problem solve. Where'd the ball go? So yeah, it should be fun. Then other things we talk about lifestyle-wise are dietary pattern, and there are a number of different diets that have been promoted. From an epidemiologic standpoint, the Mediterranean diet was found to be associated with lower risk of dementia, and not so much what they eat in Greece now, because they've got their fast food too, but more in the 70s when it was, olive oil and fruit, grain, nuts, not too much red meat, not too much animal fat, more fish and poultry. And then there are variations on that, the MIND diet and others or plant-based diets. So really we're trying to promote brain health by avoiding some of the dietary components that accelerate atherosclerosis, that are cardiovascular risk factors, because these are also risk factors for Alzheimer's disease independently. Sleep is important. And a lot of us cheat sleep and we get away with it for a while and then we don't. And what happens during sleep is memories, things that we experience during the day, get rehashed when we sleep, especially in deep sleep. And they get pruned and sorted and emotions get stripped away. So you feel better in the morning. I'm not so angry at my mom or whatever happened, but I still, remember everything that happened. We need that. Sleep is by the brain for the brain, and the immune system also benefits from sleep, but it's really an activity that the brain needs, and the brain is not quiet during sleep. The body's still, and we think, oh, how peaceful. The brain, if you do an EEG, is like you're out of your mind when you sleep, literally. It's so busy. And there are also channels that open up. They're called glymphatics that clear toxins like amyloid, and you need a certain duration of slow wave sleep, that's deep sleep, to clear those. So those of us who think, I can work an emerge shift, 2 back-to-back, whatever, who needs sleep? Well, yeah, have a nap later, buddy, because it's good for you. So we shouldn't feel guilty if we need to sleep a bit longer. And unfortunately, disorders of sleep are common. Sleep apnea and anxiety keeps people awake. So it's important to help people with that. And again, here we're not talking about anti-tau or anti-amyloid therapies. We're talking about common sense things that can actually be rather elusive for people. Lots of people struggle with sleep. So that gets into another lifestyle strategy, which is trying to manage stress. And there's no point in me saying you got to eliminate stress, because it's all around, lifestyle stress, traffic stress, financial stress, and my kids are driving me crazy, whatever, I hope they didn't hear that.
But I was in the third person.
That's right. Your kids are driving me crazy. So, But the idea is try not to let it eat away at you. Make some time for things you enjoy. Easier said than done. Many of us are very busy, but it's really important if we give that some priority and importance for our brain health to take a break. Think about the activities that are relaxing that you enjoy. Cut out some time for those. Meditation is often helpful. Mindfulness techniques can be very helpful. So it's not a one-size-fits-all, but there often is something for each person that is very helpful that they maybe haven't pursued, haven't thought about, or realized how important this can be. When we have chronic, moderate, or higher degrees of stress, we release cortisol. Cortisol is toxic to the hippocampus, our friend the hippocampus with all the memory cells. So we really need to downplay that. Exercise, on the other hand, dampens down that cortisol. And, so all of these lifestyle strategies work well together. If you can, we usually have at least one or two we can improve, even if we're perfect. But if we can kind of embrace as many as possible in some way, they are additive, if not synergistic.
So Jessica, before we close out this, anything else that, whether it's from your standpoint of being a genetic counselor or whether it's observational from dealing with patients, anything else that you'd like to add to the conversation?
I think something that hopefully is apparent is that this is multidisciplinary. It is not one person that's involved in your care. Yes, as a family physician, but you can speak to genetics without committing to genetic testing. You can go see Sharon at Toronto Memory Clinic and find out more about what's available to you, what can be done, what trials are going on. And there is support for patients. And I think the key is that patients need to ask the right questions, to talk about the concerns, to bring up their family members' concerns, like you said, and know that there are teams here to support them, and it's not one person.
Excellent. So thanks again. Eat, Move, Think works for everything.
Thanks so much, Lauren.
You did a great job, both of you.
You're awesome. You're a great moderator. Love it.
That was Medcan Senior Medical Consultant Dr. Lorne Greenspan in conversation with Jessica Gu. She's the
Clinical Director of Genetics at Medcan.
And Dr. Sharon Cohen,
the Medical Director of the Toronto Memory Program and world-renowned expert on Alzheimer's.
Amazing. All right, the Twitter handle for the Toronto Memory Program.
Yes, check them out on Twitter at Toronto_memory.
We'll post episode highlights and links at eatmovethinkpodcast.com.
Say hello and send us a tip or a suggestion by emailing us at info@eatmovethinkpodcast.com.
Eat, Move, Think. Did we miss anything? Say hello. Did I need to say that?
I said that.
You said that?
Oh, follow Medcan on Twitter and Instagram.
And follow Medcan on Twitter and Instagram at MedcanLiveWell.
Eat, Move, Think is produced by Ghost Bureau. I'm managing producer Jasmine Ratch.
Why is this so tough?
I know.
I'm executive producer Christopher Shulgin. Social media and strategy support is from Chantal Gurten, Emily Bozick, and Andrew Imax.
We will be back soon with a new episode examining the latest in health and wellness.
Oh, we should probably check out next week's.
Meh.
Yeah, we're fine.
We did it. Yeah.
I'm sweating.
People don't really listen to this, I don't think, honestly.
On the end.
I would say one more time.
Woo!
For the ending, and then I think we got it.
We were flying through it, and that's like the part that we don't say every time. We nailed it, and then the part that we say every week. Okay.
That was Medcan Senior Medical Consultant Dr. Lorne Greenspan in conversation with Medcan's Clinical Director of Genetics, Jessica Gu, and the Executive Director of the Toronto Memory Program, Dr. Sharon Cohen.
She's the medical director.
What did I say she was?
Executive.
Oh, and they're back.
Yeah,
What?
It's been 15 minutes, to be fair.
That was Medcan Senior Medical Consultant Dr. Lorne Greenspan in conversation with Medcan's Clinical Director of Genetics, Jessica Gu, and
Dr. Sharon Cohen. She's the medical director of the Toronto Memory Program and world-renowned expert on Alzheimer's.
Where can you find the Toronto Memory Program on Twitter?
You can follow them on Twitter at Toronto_memory.
We'll post episode highlights and links at eatmovethinkpodcast.com. Send us an email or drop us a suggestion at info@eatmovethinkpodcast.com.
And follow Medcan on Twitter and Instagram at MedcanLiveWell.
Eat, Move, Think is produced by Ghost Bureau. I'm executive producer Christopher Scholgen.
I'm managing producer Jasmine Ratch.
Social media and strategy support is from Chantal Gertan, Emily Bozick, and Andrew Imax.
We'll be back soon with a new episode examining the latest in health and wellness.